Hello and welcome to Beyond COVID, the Geohealth challenges of the coming century. The COVID-19 pandemic has been unprecedented within most of our lifetimes. And what we want to do in this talk is put it within its historical context and think about some of the challenges that are going to emerge from COVID and how that will affect the coming century. This is a conversation talking about global issues and historical context and future perspectives. And I'm joined today by a panel of researchers and teachers from the University of Lincoln School of Geography who've been working on topics related to this problem over the last year and beyond. So I'd first like to introduce my colleague, Dr. Matthew Hannaford, who is a lecturer in historical and cultural geography. Matthew did his PhD at the University of Sheffield, graduating in 2015, and after that he worked at the University of Utrecht, looking at how Western societies have coped with challenges to rural hazards and disasters. I'm also joined by Dr. Harriet Moore, who's a lecturer in health and well-being. Harriet joined us at Lincoln in 2018, having completed her PhD at the University of Melbourne. And during this pandemic, she's been looking at how the pandemic has affected the East Midlands of England. Finally, the last member of our panel is Dr. Crichton Connolly, a senior lecturer in development studies and the Global South. And he completed his PhD at the University of Manchester before moving to the National University of Singapore, where he was a postdoctoral fellow. So I would like to encourage you all to join us in this and use the comment section to ask questions. I will ask the panel your questions at the end of the session. But I would like to begin this conversation by talking to Matthew and asking Matthew about some of the historical context, because we all know that this is not the first pandemic to hit our society. There's been lots of talk in the news about things like the Spanish flu, and we all know the pandemics that have gone before then. So I'd like you to sort of outline what the similarities are between this pandemic and how they differ from some of the things from earlier pandemics.
Well, thank you for that introduction, Dan. You're certainly right that this is not the first pandemic that has affected Britain. In fact, one thing you missed actually was that it's a year to the day since the COVID-19 was declared a pandemic by the World Health Organization. So it's obviously very timely that we're having this conversation today. And if we think back to historical pandemics, I guess the big one that the mother of all pandemics that sticks out is the Black Death, which was actually the start rather than the end of a series of recurring plagues across Europe over the next few centuries. And as you mentioned, also the influenza pandemic of 1918-19. But of course, these are the very large scale crises. Actually, epidemics on a national scale in Britain, on a regional and local scale, were basically omnipresent throughout much of the pre-modern period. Only really in the 20th century did we start to see a really rapid decline in many of these diseases. That said, no two pandemics or epidemics are the same. So there's a saying that once you've seen one pandemic, you've seen one pandemic. Although the mainstream media may oversimplify similarities or underplay differences between past and present, there are actually very real differences. And one of these is actually a piece of, well, positive or maybe less bad news, I suppose, that mortality rates associated with COVID-19 are actually well lower than most, if not all, of those afflictions that I mentioned in the past. So the Black Death, for example, killed anywhere between a third and 3/5 of the European and British population. Influenza 1918-19 was much lower at 2 to 3%, but that's still an enormous death toll across the world as well. And for smallpox, those mortality rates varied, probably in the height in the 18th century of smallpox outbreaks. That was around up to 20% of the population. That said, there are some similarities in terms of how COVID-19 is selective in its impacts, at least at the very severe end of those in terms of mortality, where we see age and gender specific impacts. So thinking back to the influenza pandemic in 1918-19, the highest death rates were observed amongst the very young, the very old, and there was also a sort of peak amongst the working age population in the late 20s and 30s as well, possibly due to exposure to these points of contagion that we're all quite familiar with now, as well as some more sort of biological vulnerabilities. Equally, like COVID-19, there was a female survival advantage in this in the influenza pandemic. So male death rates were higher, although that's actually less clear for the more sort of pre-industrial epidemics going further back in time. There's again debate about whether we're dealing with mainly biological factors here, or whether we're actually looking at the exposure to points of contagion through things like occupation and so on.
So this would be things like men working in heavy industries in this country, that sort of factor?
In a sense, and also as you often get associations between things like warfare, where you obviously have contact in less than ideal conditions. You have facilitation of the spread of these diseases, and of course, one thing we know about the influenza pandemic, it occurred right on the tail of World War I. That's actually why it's probably not so known historically. In fact, it killed more people than World War I did, but it's talked about certainly a lot less in the media. So yeah, just to finish off, another parallel that we can see with respect to COVID and the past is that these things, they tend to shine new light on inequalities that actually may be quite hidden from view in normal times, whether those are sort of based around gender or on wealth or otherwise. So, for example, we know in the case of COVID that deaths tend to be higher amongst the most deprived, again, for different reasons like exposure, occupation, medical vulnerability, and so on. And actually, similar evidence has been found in the case of the Great Plague in London in the 1660s to the same effect. Population density as well being an important factor there. And although there may be a female mortality advantage or female survival advantage, actually those other effects of the pandemic that's having on every aspect of our life, they actually tend to fall pretty hard on women in relation to caregiving, for example. And that has also historically been the case. Final point, I suppose, not to hog too much of this conversation. I'm sure you've got plenty of questions to get through. But another parallel is actually between there being strong human environment entanglements here. So particularly thinking about human-animal interactions, which can sort of precipitate the spread of these epidemics and pandemics. But also looking further back, there have been associations made with climatic anomalies and disease outbreaks. And we've actually got a PhD student in the School of Geography at the moment who is looking at that. Those interactions in the case of Lincolnshire from the 16th to the 19th century. So plenty of parallels, but not maybe the simplistic story that you might hear discussed in mainstream media.
Thank you very much, Matthew. So actually, one of the things there you talk about at the end is that influence of the human-animal interaction with driving the current pandemic. And I think that brings us nicely on to thinking about the start of the current pandemic. I think most of us are aware that it was probably the first many of us had heard of the city of Wuhan, if we're not very familiar with China. And this was a disease that appears to have come out of East Asia. This has been a region with some really rapid urbanization over the past few decades. And Crichton, I was wondering if you could outline what some of these changes have been.
Yeah, for sure. The rate of urbanization in Asia has been about the highest of any world region since about 1980. So the population, the urban population doubled between 1990 and 2015, and is continuing to grow, but I think will soon be overtaken by Africa. So those two regions now bearing the highest rates of urbanization in the world, and also have been the sources of recent pandemics in the world, from SARS to Ebola and COVID-19. So I think there is a important relationship there, which is something that I've been doing research on over the past few years with my colleagues. And in particular, within Asia, we have varied rates of development and urbanization. China has been considered as one of the most dramatic movements of human population in history, from rural to urban areas. So, for example, in 1970, less than 100 million people in China were urbanized, and by about 1990, that had tripled to 300 million, and then by 2010, had doubled again to nearly 700 million. And so I think that rapid urbanization in China and other parts of the world has put additional pressure on resources and livestock and so on, which has also been alleged to contribute to the outbreak of recent diseases like SARS and COVID.
So when you're talking about the pressures on livestock, Crichton, what are you meaning by that those pressures on livestock? Could you just go a little bit more into that detail?
Yeah. So of course, greater demand for cheaper protein, and that is leading to greater rearing of animals for food, and that leads to sometimes diseases within the population of animals that can spread to humans. There's also, of course, illegal harvesting of wildlife for food that has been said to contribute to new disease strains in humans, and coronaviruses being one of those. And I think, we've only kind of reached the tip of the iceberg in terms of the number of coronaviruses that can extend into the human population.
And so would you say then it's the livestock, it's the proximity and the pressures on livestock that are driving these diseases, or is it something else within the urbanization processes that's driving the disease development?
Yeah, it's not only livestock. I think, the popular press puts a lot of emphasis on that. Bats, for example, which I think is being a source of disease, is relatively controversial scientifically. But I think deforestation also plays a major role, which of course creates new relationships between humans and our natural environments and different ecosystems and flora and fauna. So I think that's a factor as well. And just the greater spread of the urban fabric across the globe, which is creating new relationships and dynamics between urban and rural areas, so that more and more places around the world are being affected by impacts of urbanization.
Excellent. So thank you very much for that. I think that gives a really clear idea of those urban patterns that are involved in the present one. Just before I move on from this, Matthew, are there areas of urbanization that played a role in any of those previous pandemics, or was it non-urban factors, do you think?
Well, certainly urban areas had significantly higher spikes of diseases like plague. In fact, plague has often been sort of classed or seen as an urban phenomenon. Whilst that's not necessarily black and white, certainly the increase in mortality was significantly higher in urban areas due to things like fleas, rats being present, and transferring pathogens and transmitting, aiding the transmission of these diseases. Obviously, as well for human diseases with human-to-human transmission, urban areas were hit a lot harder, and certainly with actually facilitating the spread of these things over sort of cross-continental spheres in Eurasia. It was often along those trade routes like the Silk Road and around the Mediterranean ports and the North Sea ports that these diseases spread from one territory, one region to another. So certainly urbanization and its related economic phenomena have played an enormous role in spreading diseases.
So now I think it's worth us sort of bringing this forward and bringing it into a more local context to Lincoln. And Harriet, I know you've done quite a lot of work over the last year looking at how the pandemic has been affecting the East Midlands. And could you outline some of what's affected the East Midlands in terms of the higher and lower cases and how it's affected our region?
Sure. Interesting. So following on from what Matthew said about vulnerability and exposing vulnerabilities, I completely concur. More than 10 years ago, Michael Marmot and his health team produced the Marmot Review looking at those vulnerabilities, those health-related vulnerabilities in the UK. And before the pandemic emerged, he had another seminar and another paper following on from that review, and he very clearly said, these vulnerabilities exist. If something like a pandemic occurs, we will see the same patterns of vulnerability, and we definitely have. So, underlying health conditions, but also the geospatial vulnerabilities that people are exposed to in landscapes and those relationships between environments and societies that Crichton touched on. I've been working with the EDGE Consortium, which is an international collaboration that we have with McMaster University, the East Midlands Ambulance Service and the University of Lincoln. And we've been working with data which reflects suspected cases of COVID. Just a sort of side point to help our audience understand here. In the early months of the pandemic, it was actually quite difficult to gauge the transmission of the virus through confirmed cases, and that was largely due to the fact that community testing was really restricted as the virus became labelled a level 3 pathogen, and that limited testing to Public Health England laboratories for the most part, not exclusively, but for the most part. In those early days, community case rates were really measured by or traced heavily by symptoms, reporting of symptoms and clinical impressions of trained medical professionals of what those symptoms were. Ambulances have collated this type of data, and two of the biggest predictors that we've found, or two of the biggest associations between suspected and actual cases of COVID, have been around the olfactory disturbance, loss of smell, as well as blood oxygen levels. And this is the type of data that ambulances collate routinely. So I've been fortunate enough to be working with the East Midlands Ambulance Service in the East Midlands of the UK with this extraordinary data and its real-time opportunities for tracing transmission, as well as identifying vulnerable communities. Crichton has outlined those sorts of historic associations to urbanisation and risk. And certainly what we've seen when we've been mapping and analysing for unusual clusters of these suspected cases is that quite a few of them do, of course, occur in more heavily urbanised areas. So, for instance, we can identify clusters in places like Leicester, Nottingham, Derby, in more highly population-dense urban areas. But the interesting thing is, and this is not exclusive to the UK, these patterns are emerging in places like the US as well, is that vulnerability and high case rates and unusual clusters are not confined to these more intuitive urban centres. They also occur more regionally in rural areas and in peri-urban areas. So places in Lincolnshire, for example, like Grimsby and Skegness, are also sites of clusters. And these are places of lower population, and in some cases, like the Peak District, we're seeing clusters which are really lower population. So vulnerability isn't simply a product of urbanisation. There are some really complicated trends to do with transmission, but also to do with underlying susceptibility. So we can think about vulnerability as a sort of intersection of those exposures and transmission in built environments and urban centres, but are also related to underlying susceptibility of populations.
And just on that point about transmission, I think that's a really interesting one. What are the transmission mechanisms that move it beyond urban heartlands? Are we aware of them yet, or is that something we're still trying to understand?
It is actually so difficult to understand, and part of the reason for that is, even though the UK is incredibly data rich, in a sort of medical surveillance sense, it is incredibly hard to survey transmission at a community level. So we can do that medically, but in the early months of a pandemic, where that level of testing in community is really, really difficult to do, those transmission patterns, they take a long time to work out.
Yes, yeah. Just on that issue there of the non-urban areas, I think, Matthew, that's something previous pandemics have seen, isn't it? That famously, Harriet mentions the Peak District, and one of the most famous cases in plague is the village of Ireham in Derbyshire in the Peak District. So it's not just a modern phenomenon, is it, that these things have slightly different effects outside of the urban areas? No,
absolutely, and particularly in countries with relatively high population densities like England, like the Low Countries, urban and rural, to an extent that there is a large sort of blurred edge between the two, because you have, even centuries past, you have large scale interactions. So certainly thinking of most of these epidemics as entirely urban phenomena can be a bit of a red herring.
Yeah. And so thinking about those urban, well, any communities really, are there different things, Harriet, that increase or decrease the risk of a community being susceptible to COVID-19?
Yeah, I mean, certainly, and just a sort of reminder that at least the data I work with is emergency medical data. So we're talking about not just transmission here, but we're talking about culmination to severe symptoms of illness, which is a little bit different. But yes, the risk factors certainly vary spatially. So if I think about our urban clusters, they are predominantly more deprived areas in terms of the index of multiple deprivation scale. And there's all sorts of associations with deprivation and underlying vulnerability, like pre-existing multimorbidity, meaning multiple health conditions that contribute to poor physical and mental health. We could also relate it to health literacy, and a really important distinction here is physical compared to social health service access. So we know that there are higher rates in poorer communities. There's also, been quite a lot of evidence internationally about ethnic minorities, and one of the issues there is related to social access and cultural access to health services. So if we look at some of those denser urban areas, you have the culmination of exposure, which is very high, underlying health vulnerabilities and deprivation. If you move away from those urban centres and start to look more regionally or peri-urban, and even some of our rural clusters, some of the defining features are things like ageing populations. Now, you might have reduced exposure and transmission in these areas, but when contagion does occur, you have very vulnerable populations. You also have further physical distance from health services. So the dynamics are very, very different, and also the sort of interplay between transmission as a factor and underlying susceptibility.
Yeah. Okay, that's a really clear explanation of what leads to those more serious cases. Given we've faced pandemics in the past, Matthew, why has COVID-19 been such a shock to our society?
I think that's a really important question, actually, and one that touches beyond thinking about epidemics and actually makes us think about the whole of society in its entirety. So I can answer that in two parts, I suppose. And the first is that in recent decades, or even over a century, I think there's been this kind of air of invincibility in the West, whether within government, across the media, and many citizens as well, about the kind of level of threat that these environmental or biological shocks actually pose to us. And I think these threats sort of seem to belong to this kind of pre-modern world, or this contemporary so-called underdeveloped world, rather than that modern one with open and democratic institutions and large scientific research programs and so on and so forth. And I can probably say,
I was just going to jump in there. I think that's a really good point that Matthew raised about the unpreparedness of the West in terms of combating COVID. So there was remember there being a lot of discussion about how, this is another disease in Asia that, like previous ones, that will largely probably stay there in China or within Asia, and it won't spread to Europe. And if it does, we won't need these kind of massive lockdowns that they're having there, because we don't have that same authoritarian government. But then fast forward by a couple months, and then we have that same have to go through that same process, but a bit less prepared, because I think there was a lot of there wasn't much expectation that we would have to battle the same kind of disease.
So on that, Crichton, and I'll come back to you in a moment, Matthew, but on that point, do you think it's to do with the form of government, as in obviously China has got a very authoritarian government, or is it to do with that medical memory history? So somewhere like South Korea has had pandemics as well in the past, and obviously they're held up to doing very well in COVID-19, but they've got strong democratic systems. So is it to do with the government, or is it to do with societal medical memory?
Yeah, I think it's a bit of both. That's a good question. I think it's partly the attitudes within society as well, and culture. So in Asia, it's common to see people wearing masks even if there isn't a pandemic. If people are unwell or so on, there's less reluctance to wear masks in public. In the UK, you see people put on a mask in a shop and then take it off the second they leave, which isn't the case in a lot of Asian countries as well. And partly it's governance. So there's more, I guess, some stricter control of diseases in some Asian countries. But I think it's partly that memory of the past pandemics like SARS as well, that people are still fresh in people's minds, where we don't have that same kind of experience in the UK and other parts of the global north.
Yeah, and it is noticeable that sort of, as we see it with other aspects of disease, don't we? That as with sort of vaccine reticence, perhaps as diseases almost die away and people get less used to seeing them and less used to seeing how serious they are, this vaccine reticence increases. Matthew, I'll bring you just back in to finish that point you were making.
Yeah, actually nicely follows on what I had in mind to say after that as well, because I think following on from Crichton's points, we saw how in the early phase of the pandemic as well, COVID was sort of assigned geographical labels, another historical parallel, with it being sort of orientalized, I suppose, as a Chinese phenomenon, whether linked to under or even overdevelopment, depending on your sort of view of China. Certainly there are differing ones in political discourse. And so, yeah, a virus spreading around Western Europeans' populations seems sort of unthinkable, even in the midst of it actually doing so. I think there was quite a level of denial about, how fast this is spreading around the Western population. And that actually, I think, did contribute to the slow response observed in many Western nation states. Just picking up on the point about memory, because that's a really important point, perhaps comparatively between Western Europe and the wider West and parts of Asia. I think, when we think about the kind of measures that were put in place to try and stop the spread of historical epidemics, essentially they were very similar to what the tools we have today, like quarantine, restrictions on travel, limitations on economic activity. These are not actually unprecedented, but actually it seems that the societal and the cultural memory of European confrontations with these kinds of measures and the epidemics that can bring them about has actually been very much lost amongst most of us, and not just for things like plague, but also for the influenza pandemic, which, just over 100 years ago, it's still, at least in the kind of timescales that I look at, it's not that long. It's a few generations. So really, yeah, when Wuhan first started to be locked down, the thought was that those measures were actually unthinkable in Western democratic societies. But to what extent is that simply because we've forgotten that these measures were not historically new in Europe? They're actually tried and tested measures in emergency situations that we need to employ to stop a highly infectious virus spreading around us. So on the flip side of that, it's actually a good argument for historical epidemiological research and certainly the social dimensions of that to actually revive some of that historical memory.
That's a really. Do you think there is a way of reviving historical memory, or is it something that once it's lost, it's lost, Matthew?
I think, to use a favourite academic word, this is a case where transdisciplinary research is needed. Actually, not just maybe going to an archive and publishing a nice paper, but actually working with local communities who perhaps communities where there's sort of long histories of intergenerational, generations remaining in communities, and actually digging up some of that memory from the bottom up rather than sort of academic top-down approach. And certainly, I go back to our PhD student Holly's work, which is actually pinpointing when some of these historical epidemics occurred in sort of the very small scale rural villages that we don't necessarily hear about, or we wouldn't find about them from a Google search, for example. So actually working with communities, working with archivists, working with epidemiologists can really bring together that expertise that can actually help revive some of that memory, at least in a stronger sense than we have at the moment.
Yeah, I think there's a lot of very good points there, and thinking also that we think about COVID-19 as being the first pandemic. We've spoken about in this Spanish flu as a marker, but of course different communities have had pandemics within them in living memory. If you the AIDS epidemic in the 1980s, and then in very localized ways around the UK, there have been different pandemics. So it's not the first pandemic to hit our country. It's just the first that's hit it at the national level to all communities. And thinking then sort of beyond COVID and beyond the facts that has, I think all pandemics leave their mark on societies. Crichton, I'll bring you in here to talk about some of the East Asian challenges and the risks associated with urbanization and where urbanization goes and what effect that has on pandemics and health more generally.
Yeah, thanks, Dan. Sorry, the light's getting a bit bright there. Yeah, so as I said, the urban population in Asia is continuing to grow. The percentage of the national population living in urban areas in most parts of the world will, I think, double by the year 2050 from 2000 levels. So a major challenge is managing the rate and the scale and the degree and the concentration of growth in urban areas. So some major challenges related to this include the unplanned and uncontrolled nature of urban sprawl, particularly in squatter settlements and small-scale industries beyond city boundaries. So there was a lot of concern, for example, at the outbreak of COVID-19 about the spread in informal settlements in the global south, where people can't self-isolate or social distance or work from home or what have you. And also issues of liquid waste disposal from sewage or industrial effluent that can pose risks of water pollution, contamination of rivers and seas, which can then lead to waterborne diseases as well. increased pressure on resources and space for urban development. So that can result in deforestation, increased scale of land reclamation, pollution, quarrying, and just loss of biodiversity in general, and then CO2 emissions as well, and impacts on air quality and marine environments. So I think to address these challenges, we need better urban planning and governance, which is participatory and collaborative beyond the city level, which can include some grassroots actors and national and regional governments as well.
Yeah, I think you make a really good point there about some of those other diseases around urban areas in particular. So we haven't, we focused understandably on COVID, but one of the, just before COVID, there was the Delhi air pollution crisis that really brought air pollution home on a dramatic scale. And I think in 2019, it was about 7 million people died of complications due to air pollution in cities. And so even that puts COVID into some sort of global context of other challenges. This is one amongst a number of different challenges that we're facing.
Yeah, and I think it's triggered some discussion around how we can reorganize and better plan our cities, having the 5 mile city or what have you, where you have maybe more working from home, less commuting, and less air travel, for example. And these kinds of things can help combat climate change as well, which is a more of a long scale threat, but one that I think requires some of the same adaptations that battling the COVID pandemic has had required.
Yeah. Harriet, bringing this again, talking about some of the effects on the East Midlands, but I suppose we could broaden it out as well. The effect of some of these measures that Matthew talked about in terms of bringing in ways to mitigate the crisis, they're not net neutral, are they? They have significant health impacts on people's mental health as well. And I think you've done some stuff looking at that, haven't you?
Yeah, it's interesting, the whole theme of preparedness or unpreparedness. And, of course, we're talking about Matthew and Crichton have been talking about preparedness in terms of how the West has perceived a pandemic, and, our vulnerability and kind of the shock horror of that. And I would say on a more sort of granular demographic scale, there's that same preparedness issue when it's come to these mitigation measures like lockdown. So we've been looking at, again, it's medical emergencies, so mental health emergencies that have occurred in the East Midlands region, although, we could have been looking at the whole of the UK. There's been research about it in the US, the issues around social isolation and just the major upheaval to people's lives. And one of the trends that we've observed that I find probably the most interesting, we've compared the nature, the characteristics, the type of mental health emergencies that have occurred in the first national lockdown in the UK to the nature and type of emergencies of the mental health variety that occurred in the same period in 2019. And we see a lot more anxiety, a lot more. But we also see a higher representation of men experiencing those emergencies. And to me, this is super illuminating, because actually a lot of the very big national studies of the mental health impacts of COVID have involved self-reporting. Now, an issue with that, particularly for the underrepresentation of men, is that men tend to engage less with voluntary social surveys, particularly about mental health. Men also tend to help seek less, tend to access mental health services less. So if you look across all the different types of data that we have out there to give an indication of mental health vulnerability and impacts, well, just in general, but also during a pandemic, men tend to be underrepresented in pretty much every data you can imagine. When it comes to this emergency medical data, so culmination, again, is the key here. Culmination from a vulnerability to an emergency, to a mental health emergency that's so severe that you require an ambulance and a paramedic, men are overrepresented. And this is to me, this maybe this does have something to do with preparedness. Are we preparing young men and our male population for difficult times? And I would say we definitely aren't. There's still so much stigma around being male and having mental health challenges, and something accumulating in an emergency is suggestive of something underlying, because of course not everybody in experiencing lockdown is in a condition for that to precipitate an emergency. An emergency is a culmination of an underlying susceptibility. Mental health emergencies tend to be cumulative, the loss of a job, the loss of a partner, the loss of freedoms around lockdown. It's cumulative, one after the other, and then a mental health emergency occurs. So I think we really need to stop and look at our vulnerable groups and to challenge these ideas. A lot of the research coming out is suggesting the female advantage, as Matthew put it, which I thought was really, really nicely put, because women self-report more. Women appear in the diagnostic data more, partly because they go to see clinicians more. So there's this gender issue certainly that's emerging, and I would say that you mentioned sort of legacy and impact. Well, this is a legacy that we're going to be left with long after pubs reopen and bars reopen and lockdown is removed. Mental health is a legacy, and it's not just a legacy that is faced in community. It's also one that is massively faced by professional bodies. So if we look at our emergency medical staff, what they've been through, what they continue to go through as a result of this pandemic is absolutely massive. So I think that legacy is one that is faced in relation to community mental health, but also the professionals, and I'll say I think academics fall into that as well. Anyone who is sort of at the forefront of managing the mental health impacts, whether that's on students that we deal with, or if that is medical professionals dealing with these emergencies, that legacy is going to continue. And particularly in the coming months, as we have furloughs turn to redundancies, there's that compounding risk associated with economic vulnerability. So I think this is an issue that is here to stay for some time, and it requires our compassion and our understanding and our patience long after something like lockdown has ended. You're on mute.
Yeah, I've done it. Thank you very much. It's the first time. That's a very eloquent talk about some of those challenges that come in the immediate future after the pandemic ends. Just to bring Crichton or Matthew back on that, this conversation is called Beyond COVID. What do, I suppose, all three of you, what do you think are the biggest challenges, in a word, as we come out of this pandemic? Crichton. Whoever wants to.
In a word.
Well, in a word, as in a few words.
Okay. Yeah, in a few words, I think we'll need to develop better, more sustainable relationships with the natural environment, and that will help solve a lot of the problems, from climate change to infectious disease to urbanization, and also tackling inequalities as well, which have been brought to the fore during the COVID pandemic.
Excellent, thank you very much. So anybody else want to come in on that last point as a big challenges? Harriet, I think you seem
thank you. Sorry, just that in literally one word, vulnerability, or in two words, vulnerability, inequality. Inequality, and I cannot recommend enough, if you're looking to understand the underlying mechanisms of vulnerability, go and read Michael Marmot's reports from the past decade. On health vulnerabilities in the UK, the links between deprivation and susceptibility to illness, whether it's physical, or psychological. They're there, they're known about. They're not new, they're not surprising, but they're there. And there's a legacy related to healthcare in this country and many others that speaks more words than I have about why we're seeing those vulnerabilities, mirrored in this case of this pandemic.
If I bring Matthew in there as
I
well.
would echo both those comments, and I would also say, particularly in relation to learning from the past, look beyond GDP, look beyond GDP per capita as a mode or an indicator of recovery. Certainly, there's been literature looking way back to the Black Death, suggesting that actually inequality reduced after the Black Death. Obviously, there was an enormous difference in the mortality rate, with half of the population being wiped out, but capital being left relatively untouched. You're probably going to get some kind of natural swing back in favor of labor, but we're dealing with a very different beast compared to that. So there are other indicators that we need to look at, and we need to focus on a lot more than GDP. And certainly, I think if we could, and this actually relates to a question that's come in from Chris, number 3 out of 4, although 5 now, I think, if we're to learn from historical epidemics, we actually need to think about what we can actually measure historically. Those things tend to be wages, they tend to be land holding, they tend to be wealth. So it's all well and good making hypotheses that inequality reduced, but actually, how do we know that wealth increased across the population, or do we think it's actually just in the male segment of the population that wealth and wages increased? And if it is just in the male sector of the population, then how can we really describe inequality as reducing if 50% of the population don't share in those benefits? So really think about what we measure and think about what we value as a story for recovery.
Thank you very much, Matthew. And I think I'll now turn to some of those questions that have come in on the chat. So you tackled that question about how good the historical data is in terms of data representation. Let's have a look through some of these others. I'll leave 1 or 2, but I'll go to the second question, which is, do you think that there is a way that we can increase development without risking further pandemics? I'll throw that to any of you, really. How can we continue to develop and without the increased risks of pandemics? Is that?
I can throw something in there.
That'd be lovely. Yeah.
I think the missing narrative here, and I'm painfully aware of this in my own research, it is fantastic to be looking at landscape scale relationships, sort of more distal associations between health and landscapes. But the missing narrative is individual human behaviour. People behave, they act, and behaviour can mean everything. You can live near a green space and not access it. You can live in an area with poor air quality and not necessarily have a severe respiratory condition because of other efforts you make in your life to manage your health. There are all these relationships that are really mediated by the person and intent. And to me, urban sites are not necessarily sites, or they don't have to be sites of unhealth. They don't have to be sites of illness. There are ways to exist in urban landscapes as responsible people with intent. So I think there's a lot of hope in the power of the individual behaviour of the person to mitigate some of those risks.
Excellent, thank you. And that actually leads on to Chris's 4th question, which is, do you think these behaviours, the behaviours that we are learning in society today during the pandemic, are they going to stay with us? I think I'll throw that to any of you really, but certainly one of the things Crichton said during his talk was mentioned about mask wearing in East Asia, and I think before the pandemic, it was definitely an anathema to many Westerners of why people did that. But I think we can understand that in a much better way. So do any of you think that behaviors are going to permanently change coming out of this pandemic?
Yeah, I think certainly they will. I'm not sure how, of course, they will change or to what extent, but I think that is something that we could certainly study through primarily qualitative research, interdisciplinary research that would take into account different sort of cultural and spatial factors. Yeah, so it'll be interesting to see, and then how long those changes last as well, or when they start to occur.
Did you want to Harriet? Yeah, please.
I was going to say, can I ask a question to Matthew?
Yes, you may. Yeah.
Matthew, what do you think of the permanency of behaviour change in light of memory? You were talking about sort of our memory as a society.
Yeah, I think I'm generally quite skeptical. I think people will forget either intentionally or unintentionally, because a lot of these measures are still perceived as maybe necessary, but actually repressive on the whole. And I think personally, I'd have no problem with wearing a mask if it reduces the chance of more spikes. But I think maybe I'm in the minority. I think a lot of people want to throw them off, and maybe mask wearing is one of the lesser burdens. But actually, when that becomes associated with things like economic damage, limiting capacities in hospitality venues, I think there will be, as I said, intentional or unintentional forgetting of what we've been through within maybe years, maybe not months, but certainly I don't think we're on a trajectory for irreversible change, unfortunately.
Okay, thank you very much. That's about all we've got time for in this session. So I just to wrap up, I think we've seen a really interesting conversation by the three academics here on the panel. We've seen how vulnerabilities of inequalities affect these things, the pandemics. Seen that it's not just the first pandemic, and the importance of memory within societies in having the susceptibility to these pandemics. And we've also seen the challenges of urban, the challenges of urban areas within these pandemics that also link into inequalities and these challenges. So, the final point I thought that came out really well was this difference of how pandemics affect different genders, so how they affect men and women differently. So it just leaves me to say thank you very much to the panel for your time this afternoon. You gave a really interesting conversation there. Thank you for those of you listening online, and thank you for the questions, Chris.